So we'll be starting. Good afternoon, everyone. First of all, let us thank the Indian Society of Critical Care Medicine for giving both of us the opportunity to take this session for you all. And we welcome you all for the next session of structured teaching and educational program for the nurses. Over the last multiple sessions we have been taking for the nurses, it has been really beneficial and a very good initiative from ISCCM, and we have multiple leaders talking about various aspects which are beneficial for the nurses, which ultimately improve the overall quality and outcome of the patient. Today, we have an interesting topic being taken by a good speaker and one good friend as well, and none other than Ms Naga Sireesha. She's a nursing leader from prestigious CMC Vellore. And now she is presently working as nursing superintendent of Apollo Hospitals, Jubilee Hills, Hyderabad. Welcome to you, ma'am. Thank you for sparing your time.
Thank you so much, Dr. Deepak, and thank you for this ISCCM for giving this opportunity. And this is the prestigious moment for me because this is a heart-touching topic which I really wanted to contribute.
Yes, ma'am. Thank you so much. So coming into the topic, it's a very vital topic, the nursing key performance indicators. So we all know there are various indicators for any process. You have indicators at the structure level, you have indicators for the process, and ultimately the indicators which are the ultimate outcome of the patients. To do this interesting topic and very vital topic, indicators will be taken care. Over to you, ma'am. Please go ahead.
Thank you so much. And I just wanted to tell you about what is indicator. Like as introduction, you all know in the nursing or whatever, if you buy anything or whatever in introduction, I just wanted to bring you to your notice that anything that you wanted to go about, you always wanted the quality. And you always wanted the indication, like how far it is, like you can use the things. So this is very important in nursing key performance indicators in the nursing as such. As you all of you know, whether it is ward, ICU, whether it is in, we come to the patient satisfaction, whether it is come to the hospital, these indicators are very, very important. So I just wanted to introduce what are the key performance indicators. In that, first one is, all of you know, which is very, very important, foremost important thing in hospital wide sector is fall. Fall is something like no matter, and this is quite challenging. I just wanted to elaborate in the indicators itself, quite challenging, like in the hospital who is 400 bedded, which is 500 bedded hospital where patients come with the attendance. Still, it is a challenging part for the hospital staff and nursing staff and the medical team. So the prevention of fall is very, very important, which increases length of stay of the patient and of course financial impact and legal liability. Second one is pressure ulcers. This is also increases the patient length of stay, and worsening also will make sure worsening also makes patient very unhappy, like no dissatisfaction. Coming to the medication errors, which is nothing but which is far most important. It is like a process from the prescription, from the transcription, from the dispensing, from the administering. These all steps we need to be very, very careful in administering the medications. Fourth one is phlebitis. Fifth one is NSI, and sixth one is like a voice of customer. You all know why I kept it last, because even though these 5 parameters are very, very important, sixth one is the most important. And there are many things, like if you do in the ICU or what to satisfy the patients, you might take care of the patient well to prevent the fall. You might take care of the patient in the ICU without forming the pressure ulcer, or you might take care of the patients very well without having any medication error, dilutions, everything giving properly in ICU, everything. Then, but still, we will fall into the area where voice of customer, which is very, very important, because in the voice of customer, because ultimately patient should say, our attendant should say, our care is good in ICU ward. And coming to the fall, you all know what exactly the fall is. Fall is nothing but loss of upright position. So initially when we are doing this fall project or anything in our hospital, we always used to say, try to defend, saying that no, patient did not fall, little only touched the ground, our patient was holding on to the wall, something like that. But whatever it is, the fall definition very clearly says that loss of upright position that results in landing on the floor. touching the body to the ground, which is very, very important. So whether you can make it as assisted fall or fall, fall is fall. Any change of position in the posture, which touching to the floor is fall. So how we calculate, as all of you as a nursing leaders are nursing, as a nursing staff and team leaders, everybody should know how to calculate in the quality indicators, how we calculate the falls. Numerator is number of falls in a given month. So suppose in a month, if we have two falls by denominator number of the patient days, how many days patient stayed into 1000, which gives the fall indicator for you in the percentage. As I already said, any change in the position, which is very, very important. And you all know how the fall can happen. So just have a picture in your mind. Small case scenario I just wanted to tell. A patient who had a fall at home, maybe 70 years old man who came admitted with the fall at home. So with the attendant, patient was admitted. So can be a medical conditions which come into your mind. Second thing is patient already had a history of the fall, high risk for the fall. So even though an attendant was there, sometimes you please try to understand even how much our education we given, attendant is with the patient, but still most of the patients, if they are little are able to recover from the disease or whatever it is, they all want to be independent. So no patient wanted assistance unless they are really sick. So they all, even though how much education we give, how much we try to protect them and how much we try to do, because nursing, we keep so much of pressure on them. Have you given education? Did you monitor every 2 hourly? Did you go to the patient? All that we try to ask so much. But we, as a nursing leader, I always find it difficult when any fall happens, trying to say the nurse have done everything, but sometimes the patient and patient attendant also, like, no. And I can understand the patient attendant side also, because the attendant can be changed. Attendant can be feeling sleepy because whole day patient, maybe attendant was staying with the patient, things like that. So the fall is utmost important. It is not only the medical, it is not only the nursing, it is various predisposing factors that can cause the patient. We can assume that these are the patients are high risk for fall. In that, which one is medical conditions? In that, stroke, incontinence, Parkinson's disease, dementia, medications, narcotics, sedatives, antipsychotic, antidepressants, antihypertensive, anti-epileptic, insulin, diuretics. Coming to the second type. Second is psychological aspect, which is sometimes patient will be depressed and sometimes patient is not immobile patient. History of the fall. As I rightly said, one example I have given, patient who had history of the fall at home. Again, coming with the same history, we should be, it is a high alert for us. Like, no, this patient might fall again in the hospital, and changed in the sleep cycle, encephalopathy, a gait imbalance, impaired vision. And environmental, which is very, very important for us in our hospital. The environment is very, very important. Poorly fitting footwear, inappropriate spectacles, and poor lighting, lack of support, grab bars, inappropriate clothing, and wearing like no clothes. In this, I wanted to tell you example. There was a fall which it was a witness for me when the patient was sitting on the cot and patient wanted to just adjust the TED stockings, which we keep for the patients. When he's trying to adjust the TED stocking, keeping the legs on the footstool, just like that, he just slipped from the footstool. So anything can cause the fall. It is the learning or take home message for us, because we never expected, like, no, TED stockings are little slippery. So he's trying to hold on the footstool. Footstool is also slippery. So we understood that, no, this is one of the important thing that we should be very, very careful to prevent the fall. And you all know modified MODS fall risk assessment, which is very, very important. In this, all these parameters are very important. History of the fall, secondary diagnosis, any ambulatory aid, and any patient is on heparin lock, gait, and mental status, any medications, as I already listed what are the medications, and physical restraints and fluid restrictions. And in this, the score is very easy for anybody, can make it very understandable. It is like high risk is 45 or more, and it is moderate is 25 to 44, and low risk is 0 to 24. And what are the interventions? That if the risk, based on the risk, if it is low risk, So what I feel is oncology patients, chemo patients, dialysis, ICU, and endoscopy, cath recovery, all OT, cath lab, all these patients, irrespective of anything, they all are, whether it is age, whether it is any comorbidities, all these patients are supposed to be considered as high risk patients. So in that, if I just wanted to tell, low risk is like bed is in the lowest setting, encourage continuous whenever the patient want to go to washroom, if needed, help only. But in the moderate risk, you need to ensure, you need to talk to the patient and say, when you're getting up the bed, you should be careful, you should call for the assistance and make sure that the side rails are up. Same thing like high risk. High risk, sometimes more than giving education, and because of various falls that we experience in our hospital, we are nowadays we are like instructing the patient and the patient attendant. We are trying to tell the examples also. Sometimes it may not be good saying that if you have a fall and you will have a fracture, again you have to stay in the hospital for a long time, may not be correct. But we come to the, at times, no, we have to tell what is going to happen for the patient. Otherwise, sometimes patient and attendant also won't take it seriously. These are the high fall risk prevention, moderate fall risk prevention measures. I already explained low fall risk prevention methods. What are the top 10 interventions which are very, very important? Check the parameters which put the patient in high risk of fall. And like what I said, slippery floor, washroom, there is no grab bars, there is no proper lighting, and their footstools are slippery. And when they're getting up also, sometimes they don't have anything to hold. These are the parameters that we need to check where the patient is high risk of fall, and provide education. And as I rightly said, how much our education, we need to clearly instruct the patient not to get out of the bed because you are high risk for the fall, and needed some articles to be kept reach. As I rightly said, little cup of water next to the patient locker. Our patient have some specs near to the patient. Our patient wanted to void or whatever it is, urinal, bedpan within the reach of the patient, so that patient won't be able to get up and strain himself. And side rails should be raised always. Bed should be locked. This is very, very important. Sometimes while shifting the patient from OT recovery, from the recovery to the bed, we should be very, very careful. Bed should be locked always. And one important thing is bed is at the lowest position. So you all know now, most of them will have electronic cords, but still this is one of the factor. Call bell is within the reach. Bathroom floor is dry and not slippery. Education is provided to the patient and family, and use the nurse call bell always whenever required. That is about the fall. Coming to the pressure ulcer, which is very, very important. Pressure ulcer is a localized injury. Like, no, it is an injury that can cause for the skin, and it is depend upon the stages, whether it is just starting with the blister, stage 1, coming to the stage 2, coming to the stage 3. So always nurses are the only responsible people who supposed to take care of the pressure ulcer, because even though the medical team is there, they will agree, they also will help us how to prevent the pressure ulcer. Like always, like when we have in ICU, where we always talk with intensivist, and they also give us suggestions. If anything, like patient is prone to develop pressure ulcer, how we need to do the measurements, and how we need to be careful, and how to calculate this as a hospital wise indicator also. Same thing, number of patients who develop new or worsening of the pressure ulcer in a given month divided by number of patient days into 1000. Hospital-acquired pressure ulcers are growing concern in healthcare delivery due to the patient morbidity and treatment cost. As I rightly said, fall and pressure ulcer increase the length of stay, and patient satisfaction decreases. Risk assessment. How do you risk? At times, what happened? There are patients who are ICU patients who discharge by DAMA, or who discharge to take home, and again those patients will come back. Once when they come back for admission, that is the first point of assessment, which is very, very important, because on admission the skin inspection is very, very careful. No, unless it is like patient who is going to be ventilated, patient who is going to be anything to be done. Other than that, remaining all our parameters, assessment should be very, very important. on transfer of the patient to the another clinical area prior to discharge from the hospital. As I rightly said, admission is important. Again, shifting the patient from the ward to ICU, ICU to ward is very important to inspect the skin. Third one is during discharge, which is very important, and inpatient conditions. You know, in the inpatient condition, we always maintain every shift. If the Braden risk assessment is 12 or less, patient is in high risk for the pressure ulcer. And the Braden risk assessment is 13 or 14, moderate risk assessment. And if it is 15 or 16, low risk score we can give. What are the factors? Like how we have factors for the fall also, we have the factors for the pressure ulcers. Can be pressure, like what are the extrinsic risk factors? Can be pressure. They are high intensity, like high pressure must be duration and the individual tolerance. There are three things I want you people to remember. One is why this pressure is, maybe patient nutritional condition, maybe the pressure where intensity of the pressure the patient is lying down, and what is the duration, how long the patient is lying down on the same position. These are very important. Sharing, which is very, very important. Deep necrosis can occur when the sharing between the two layers of the tissue leads to stretching, kinking, and tearing of the vessels in the subcutaneous tissue. This is also we need to observe. Third one is friction. It occurs two surfaces move across each other. It often removes superficial layers of the skin. Friction damage often occurs as a result of poor lifting techniques, improper bed making, placement of the draw sheet. So this where our own we try to make mistakes is sometimes when we give bath, sometimes when the patient pass motion, like when we change the sheets, sometimes the wrinkles, sometimes we try to ignore. These things also can cause the friction to the patients, and there will be changes of the skin. These are the some of the position. See, when a patient is sitting, where are the pressure points? Shoulder, buttocks, ball of the foot, and heel. If the patient is lying down on the side, which are the pressure points, which is ankle, knee, hip area, shoulder, and ear. And sometimes we give importance to all the parts. Sometimes we forget to give importance to the ear also. There are incidents we have seen ear also developing the pressure ulcer. And on the back, supine position. If the patient is continuous supine position, what all things to be careful? Back, head, shoulder, elbow, sacrum, heel. And coming to the very interesting topic, and which all of you should know, because most of the time when they report to the in charges or ANSs, whoever is the managerial level, when the staff nurse reports, they try to get confused. What is pressure ulcer? What is incontinence associated diarrhea? Which very, very important. So appearance in pressure ulcer, it will be defined area of injury, usually over bony prominences, but IAD will be irregular edges located in the perineal area. Injury starts on the inside, move outside for the pressure ulcer. But in IAD, it starts top layer of the skin and goes inside. And it causes pressure and shear, but in IAD, moisture and friction. Color of the pressure ulcer will be red, yellow, brown, black, purple. But in IAD, it can be red or shiny red. Odor, foul smelling when bacteria is present, and skin may smell of ammonia. Depth, partial or full thickness damage, but in IAD only it will be partial thickness of damage. Tissue damage may be necrotic tissue, no necrotic tissue will be here. Symptoms, pain or itching. This is also pain or itching. Treatment, provide pressure redistribution and moist wound healing dresses. And in IAD, apply moisture barrier ointment paste or cream to prevent the infections. And this is pressure ulcer and sensory perception, moisture, mobility, activity, and friction and shear. Coming to the skin bundle, which is very, very important. This is also for the assessing the skin to prevent the pressure ulcers. S is surface. Ensure patient is on the right support surface. Make sure patient not lying, sitting on the tubing. Take extra precautions. and keep moving, encourage self-movement, reposition of the patient, inspect the skin, document at every position of the change. And most of all of us, like when in the patient care area, we do everything. At times we forget the documentation. Like today the skin is okay, tomorrow patient having IAD, and slowly there is a skin discoloration. We try to ignore, like no, we try to forget, maybe because of lot of pressure as they are running around in the ICU. But if you don't document how the pressure ulcer sequences are taken place, we won't be able to understand. Incontinence, meet patients toileting and continence needs, keep skin clear and dry always, nutrition, which is very, very important. This is Braden scale assessment, which all of you must be knowing. Coming to the very important topic, medication errors. So in whether it is fall, whether it is pressure ulcer, whether it is coming to the medication errors, these are all vital parameters which is important in the patient care area. A medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient or consumer. Such events may be related to the professional practice, healthcare products, procedures, systems, including prescribing, order communication, product labeling, packaging, and nomenclature, compounding, dispensing, distribution, administration, education. So in this medication error, I just wanted to inform that most of the area, we can never say in the hospital when we have 400 to 500 patients where we have medication errors 0. And we always in Apollo report highest medication errors, and we will have a very good mechanism, like the pharmacist will, when indent, and every month we will be able to close that medication errors, how many medication errors are there, and every week we are having a medication huddle. So we ensure that in the small unit also we discuss what we could have prevented to prevent this medication errors. So this system is very stringent and it is very important also. Where do usually medication errors occurs, which is first is prescription, 39% of errors, 49 are intercepted. And same thing, transcribing 12 errors and 33%. In dispensing, 11% of errors and 34 are intercepted. And in administration, only 2 are intercepted. What I'm trying to say is, previously when we used to work saying that medication errors, there is one nurse who is going to indent the medication after the doctor write the prescription, and she is going to get the medicine and she is going to give the medicine. So now I always feel as a nursing holistic system, and we try to, because we want nurses to be spend more time on the bedside, we have delegated few responsibilities to the few. So when now we have a good robust system that where the pharmacist will indent. But sometimes what happens, ultimately we are responsible when the medicine we are giving to the patient. What happens, suppose a patient example, Tyranome tablet 0.5 mg or 1 mg is 1 microgram is intended for the patient. Maybe the pharmacist would have intended 10. So 1 can be 10. So if whatever she is intending, when I go to the patient side, my primary responsibility is to check the order, which is very important. If you don't check the order, whatever is there in the cover, I can't say I went and given to the patient, because that is why IPSG plays a very, very important role. So you have to ensure, when you're taking the file with the patient, involve the patient saying that, sir, excuse me, today is now 2 o'clock. I'm planning to give, this is the tablet, this is the dose. So when you start speaking to the patient and checking the file, I'm sure if any prescription transcription errors will not reach to the administration errors. I don't accept when pharmacist intended 100 mg, but I also given 100 mg. I don't accept, because we are educated, and even in the nursing, pharmacology is one of the subject. Even though if we don't know every action, we are supposed to know before giving the medication action, but the wrong medicine should not reach to the patient, or wrong dose should not reach to the patient, which is very, very important. Causes of medication errors, as I always says, SOP training, knowledge about the drug, patient information, feedback. In this, I wanted to add one more point is, like medication administration time. Sometimes what happens, the nurse will be busy in like no one side call bell will be the ringing, one side one patient comes and asks some query, one side another person will come and ask, one side another doctor comes for the another round. So with all these things, there are chances for the person to make a mistakes in the medication error. But I always tell them, when you do the medication, please don't concentrate on anything. If the call bell rings, some other nurse will go. So have a clear in your picture and have a peace of mind when you're giving the medication to the patient, which helps the prevention of medication errors. These are the medication errors as I from the beginning describing: prescription, transcription, dispensing, administration. Coming to the adverse event. Adverse event is which is very, very important. It is defined as untoward medical occurrence that may present during treatment with a medicine, but which does not necessarily have a causal relation with this treatment. Severity of the scale, which you are supposed to know: ADR level 1, level 2, level 3, level 4, level 5, and level 6. Level 6 is nothing but which is directly or indirectly led the patient's death. Coming to the fourth indicator, which is phlebitis. Peripheral intravenous catheter produces considerable morbidity because of frequency of the catheter insertion. This is also very important when any nurse go to the bedside morning time itself, when she's seeing the patient, she need to see what IV fluid is going on, whether label is there, how is the site, and just inspect and see, just touch and see whether the patient is having any pain or not, which is very, very important. This phlebitis also, how we can calculate number of phlebitis by number of IV cannulas injected in a month into 100. And type of phlebitis, you all know: mechanical phlebitis, bacterial phlebitis. And how we assess this? VIP score, which is visual infusion phlebitis score, which is very, very important. Coming to the needle stick injury, which is the concern of the hour. It is like our staff also should be very well taken care, because sometimes I don't say that is negligence. Sometimes it is maybe busy or whatever it is. They try to keep the needles in a side and they just dispose. They just in a hurry, they just throw and come off. So these all lead needle stick injury. Accidental injury or break in skin produced by any sharps which cause needle stick injury. And for the how we calculate how many NSIs, number of needle stick or sharp injuries in a given month into 100 divided by number of patient days in a month. And we had a campaign many times. Campaign slogan is one needle, one syringe, one time. So you should not use reuse and you should not recap, which is very, very important. Before finishing all these 5 parameters, I just wanted to tell every hospital and every attrition, every area we have challenges, but which is very, very, the most important is how you are going to handle these challenges. I just wanted to tell you some examples. So at times we feel like, no, we are in a hurry, and we used to have sharp disposers in the dirty utility for NSI prevention. Always the staff used to carry the needles in the tray and come to the dirty utility and dispose. But now we understood that no staff need to walk around and the motion study. So we provided sharp containers bedside itself. So each bedside, once she is given insulin, once she is given whatever it is injection, she can dispose the sharp in the sharp container, which helps the staff, saying that at least we reduce the time, the way the staff is moving around. That is one good thing, practices that we are doing. Second one is sometimes when any of the medical team are doing procedures, if they wanted to dispose the big catheters and all that, sometimes the small sharp container may not be enough. So we thought we'll just get the big sharp container during the procedures. There are certain things our side we can think which helps the staff and medical team and the people and who can which is like not getting into the major problem. So these all out of so many things that we discussed, and every time when we have any error or any NSI or any fall, in detail we discuss, and we want to come out what is the best that we can do from the employee point of it and from the patient point of it. So as I concluded that 5 things that which are very important, fall and pressure ulcer and NSI, which are very, very important, and we can prevent, but in the hospital setting, I'm sure all of you agree, it is not, it is easy for us to say, keep saying nursing, you give introduction, you make sure that call bell you attended, you make sure that the fall need to be prevented. In the hospital fall, it will be nursing negligence only, but so many things will come on our head. But still, our continuous efforts should not, we should not lose the focus. In spite of everything, if the patient had a fall, our responsibility is to take care of the patient, ensure patient is discharged with the good care. Coming to the VOC, voice of customer, as I rightly said, which is very, very important, one of the very important parameter to assess the nursing and patient satisfaction. And VOC ratings attend to of the call bell response, as I always, it is also, I can say it is a quite challenging in the hospital setup, because every time call bell rings, the nurse will be busy with one of the room, but call bell will be ringing. But patient ultimately writes a complaint saying that there is a delay in call bell response. So every time we try to do the audits, and we ensure that at least within 1 minute or 2 minutes, staff is attending the call bells. And adequate timely communication. Most of the times, the nurses are very good in doing things, skills are also good, but they don't communicate. Suppose if they ask, this medicine can be taken now, the nurse will say that I'll just ask the doctor and come and say. Again, coming back, maybe she will be occupied with other work and she'll forget. So the timely communication is very, very important. Post discharge instructions, I completely agree. During discharge, it is not the only the doctor is responsibility, it is nursing responsibility as well, as because very important whether how to take care of the drains, or sometimes if the post discharge, what are the precautions, whether they can climb the steps or they should not exert, or what all the things that they need to take care, some post operative precautions before going to the discharge. And when it is very well, I remember when we worked in CMC, when we used to go for community health postings, we used to give very good education. After 2 or 3 days, when the patient is discharged, come to the home. The home education is very, very important. We ensure that all these education parameters are fulfilled. Then coming to the medication timeliness and explanation. And nowadays, because so many things, either with the ratio or with the attrition, whatever it is, the staff try to go and just give the medications. They don't explain this medication is for this medication is this for. So this explanation is lacking nowadays. So it is very important. And there is nothing in nursing other than like, no, we are retraining and reinforcement saying that which are important parameters. Positive feedbacks for nursing. As in VOC, how we take care of negative complaints very seriously, we need to appreciate the nurses also who are very good in skills and who have really taken care of the patients well. Coming to the nurse-patient ratio, which is very, very important. As per the norms of INC, and all the nursing leaders will struggle with this ratio, 1:6. And for the wards and ICUs, 1:1 ventilator, and for non-ventilator patients, 1:2. Coming to the OT, 1:3. As you all know, 1 scrub nurse, circulatory nurse, and technician. Why I have kept it is always challenging, because it is always challenging forever, because the most of the nurses who come here for the experience only for 1 year. Recently, before COVID, they used to stay at least 2 years. Now, because of the after COVID, there are many opportunities in abroad. They all are coming for 1 year. That 1 year moves very fast, because they will be in induction 1 month. After 3 months, they will try to start learning things. Again, by 6 months, they will be prepared, saying that this staff is good. She knows everything. She's knowledgeable. She's skillful. The moment we think, again, that 6 months will go very fast. I'm sure everybody will agree for that. And always the intensivist also keep saying we have juniors. This is forever struggle. We are not going to retain, we are not able to retain the nurses because they go for abroad. And for this reason also, I will say most of the girls who are studying, they will take a loan or whatever it is, because they wanted their parents to be happy. So they wanted to earn and come back and make sure that everything is settled. So whatever the pay we are giving, and they wanted to go for abroad for the skill enhancement, plus obviously pay also very, very important. And with all these things, this is one of the very interesting topic. Most of the time we forget to take care of our own nurses, which is nurse burnout. And what are the causes? Which is the burnout is the state of mental, physical, emotional exhaustion caused by the sustained work related stressors such as long hours, the pressure of quick decision making, and the strain of caring of the patients who have poor outcomes. And recently, not recently, even our study period also, we used to always, when we take care of the patient, we go back and we always have some kind of trauma in our mind. So the moment that you are very moved to close to the patient and speak to the patient and know about their financial, know about the family, know about the health condition, and you will be more saying that no, more worried about the patient. And you put so much of effort. If the patient outcome is not good, and obviously that stress also taken care by the nurse. And most of the nurses, they all work very committed, saying that with so much of passion, and they always feel the patient should come out whatever the reason, like no, whatever the condition, but they always want to be positive. They always want the patient should come out in a very healthy manner. But at times when as God decides, if the patient is not able to make up, the nurse is also equally have some kind of trauma, like no, which is very very important to understand the nurse. Like sometimes we give because of the attrition, the ratio also, number of patients also we give more. Sometimes long shifts, I agree. There are times like no, we tell them only 12 hours. Like if night they do 12 hours, it is very hectic for them. And night, no matter whatever it is, night if you don't stay for a long time, and 100% daytime, how much ever you want to sleep, you won't be able to sleep. But it is very important, most of the nurses, when they do 12-hour shift, we need to ensure they are relieving on the fast. Stressful specialties, like you all know, especially emergencies, ICUs, cath lab, these all areas are very vital and stressful because the turnover is very fast. Like no, especially in emergency, you receive the patient, stabilize, and again you shift. So this also causes some kind of stress on the nurses. And the impact of the nurse burnout is more infections, lower ratings, higher mortality. So in this, what I'm trying to say is, the no matter whatever the challenges are, the upcoming trends, upcoming benchmarks, upcoming so many specialties, all these things together, when you put together also, it is very important to take care of the nurses also. So here the payment is very important. Nurse, wherever the staying, like no, hostel facilities are important. In between, at least some kind of break for the nurses are very important. At least some kind of refreshments are very important, and some kind of monetary benefits are very important. And rewards and recognition, that most important is rewards and recognition, because everybody who does hard work, they all wanted to be in a highlight. Like no, when they work with the heart and soul, they all wanted to be recognized. So I feel these are very very important. I just wanted to tell you, take home messages are key performance indicators play a vital role in achieving the patient satisfaction. And pressure ulcer fall will increase length of stay, which I've been from the beginning, I've been addressing that point, because that causes the increased length of stay. And it's important to take care of the staff by addressing the burnout syndrome. As I told you what are the reasons, as I've suggested you what are the problems, and these all will make sure that staff feel comfortable. And before ending the session, I just wanted to tell you, there are a couple of examples that I just wanted to inform you. One is like pressure ulcer. And sometimes when the patient comes to in the hospital with the pressure ulcer, community acquired pressure ulcer, but it doesn't mean that anyway patient came with the pressure ulcer. Most of the time, because I'm seeing that sometimes the staff answers saying that patient already came with the pressure ulcer. So it doesn't mean that we should not take care of the patient. So patient even come with the pressure ulcer also. It is our responsibility to take care of the, to reduce the pressure ulcer. Like no, patient should not worsening situation, should not go with the worsening situation. And that also plays a major role. Sometimes most of the patient, why I'm saying, the moment when you select the nurses, whether it is intensive care area, most of them properly they won't eat, or they themselves are very thin, they themselves are having nowadays back pains, even the younger age. they all come with the back pain. So position changing is very, very important to prevent the pressure ulcer. So these all factors also contribute for the nursing side, saying that no, they all need to have a proper hydration, proper nutrition for the nurses also to take care of the patients. And the pressure ulcers also both, not only community, whether hospital acquired, plus even device associated pressure ulcer also, we should be very, very careful. When you apply the BiPAP, make sure that you apply the silicone tape or whatever it is to prevent the pressure. Patient should not develop because of the device. Example, TED stocking, BiPAP, so many things like no. When you apply on the patient, you should be very, very careful. Coming to the last, fall is very interesting or very I just wanted to reinforce on fall because I'm quite facing challenges regarding the fall. Like, no, whether it is you given education good, but you told to the attendant, you told to the patient also, and you kept the call bell nearby, everything. But still, at times, patient tried to get up from the sleep and go and had a and fall. So you need to remember always the patient and try to, at least if you give any laxatives and all that, make sure that you do frequent rounds to the patient, at least 2 hourly, 3 hourly, and keep reinforcing the patient. If you get up from the sleep, you might have a fall. So make sure every fall, please try to report. That is what we do. All the falls, we make sure that we make incident and post-fall risk assessment we do, and make sure that a patient is stable or in immediate X-ray as per the doctor. And if the patient had any fracture or anything, we do surgery. We ensure that again patient is going back safely to the home. That is our responsibility. So coming to the last, but it is not least, prevention is always better than cure. That is what I wanted to tell you. Whether we cannot say we have done everything, but still it happened. But this is always challenging. We have to put our efforts not to increase these indicators, and which lead to the patient dissatisfaction and length of stay will be increasing. So we have to put our efforts, ensure that these parameters are taken care properly. Any questions?
Thank you, Ms Sireesha. Very insightful and passionate lecture from you, and a very key topic. Before going on to the MCQs, I think a couple of questions which were raised from the audience. So most of them wants to know how you actually solve the in real case scenarios. For example, there's a new joinee, maybe a fresher nurse. She has seen a kind of a sick case, and as you rightly said, no, she's in kind of stress over the next day. She wants to just go home and go back to her own place. How do you address her stress and burnout?
And it is, thank you, Dr. Deepak, very right questions. This is the, we often face this problem in our system also. The staff who come here nowadays after COVID, they don't have a practical experience, even checking the basic things after giving proper induction, which I feel induction is very important. Like nowadays in the induction, instead of making them to sit and show PPTs and instead of theory, we wanted to make them to practice whether PP or whatever it is on each other. Second thing is buddy and mentor, which is very, very important. Suppose if I come to one area which is I'm new, I'm traveling from Kerala, came for the job here, and I got into the job. I came to the area, and whether it is ward or ICU, I don't know anybody, whether it is in charge, whether it is doctor, whether it is any other, and there's too many things together. Diet entry, one side diet we need to get, one side medical. These are all things that staff nurse need to cope up. Means we have started newly one logbook system. We give the induction employee after induction logbook system, and 1 month we are giving a time. I know it is very difficult from our management side also to spare a nurse without giving the case 1 month, but I completely agree. Staff required 1 month to get settled to take care of the patient, and every day their classmates are their in charge. Every day, end of the day, she should speak, how was your day, and is there any concerns, whether any seniors are like asking other things to do. All these things the in charge need to take care. So we have the challenges. The 3 months the staff will be okay, third month staff will go. Sometimes we don't know the reason. Sometimes they say health conditions, sometimes they say it is too much of pressure. So these are continuous challenges.
Thank you so much. As I think you rightly said, and one of the audience also has pointed out, you take care of yourself and your bodies first, and ultimately you can take care of the patient much better than the previous one.
Correct.
And another question from one of the audience was, if there's any medication error or some kind of error was done by one of your staff, what is the actual scenario, how you address it?
So rightly asked, this medication error is quite challenging because every month we report so many medication error. If the staff had done, suppose staff had given wrong medication, our staff did not give, our staff given less dose. We started a culture to report, saying that we should not hide any mistake. Like no, if I create the culture saying that it's okay, you repair and report, and we will try to educate the staff. Maybe you did not take the file, maybe you were confused and you did not escalate the matter to the next person. So things like that, if we keep talking to the staff also feels it is okay. Like no, to reporting is more important than hiding and harming the patient. So that culture, if we start bringing in the staff, that is more enough. It is not like termination and those things. The very carelessness attitude in giving medication address, we will be able to identify the nurse, like know how she's given, whether it is intentional. Most of the medication errors are unintentional. I agree for that. But at times, if it happens also, we need to say, we need to reinforce the staff. So punishing the staff, I don't think we will gain anything, but we need to put complete efforts on the staff to teaching and training and again reporting. She should feel the atmosphere should be like, no, she should not feel that no, if anything I say, they might give letter. That kind of atmosphere we should not create.
Right. Very correct. And I think, as you rightly said, it should be a no blame culture. And as it's most of the quality books, the first thing would be to err is human itself. So any human being can do the error. So we'll be taking the questions if there's a time. We'll be moving forward to the MCQs. It's up to you. Kindly share the MCQs. Yeah. So I would request the audience to go through the question. Ms. Sireesha, you can read up the question. If someone points out the answer, I'll read it up for you.
A dash is a sudden loss of balance that does not result in a fall or other injury.
So the audience can actually type the answers. And if you have any doubt or if you don't agree with us, we'll be more than happy to take that argument with you. Okay. Yeah, we can go with the answer, please.
Yeah, this is a fall is a sudden loss of balance. Yes,
So
correct.
someone has said, yeah, one is an accidental fall, second thing is a fall, a near fall. How do you differentiate between three of them?
Accidental fall is like, as I already explained to you people, like no, if the patient, everything is normal, suddenly patient had a fall. And if it's a sudden fall, balance lost is like no, the fall really happened, like no, lost the balance and really patient had a fall.
Okay. So the second question.
The patient's risk of harm from falls will be evaluated by which score?
So must be easy one.
Yeah, already somebody answered. Morse called risk assessment.
Good. So do you have any other scores which are much simpler ones, Ms. Sireesha?
We have for pediatric Humpty Dumpty's score. Other than that, this is the only thing universally they're using.
Yeah, next.
Examples of medication that may impact patient's psychological balance. Sorry, physiological balance. These, what are the medicines which lose the patient? D. Somebody answered, very good. Diuretics, hypoglycemic, laxatives. All above are the answer.
Very good.
Next one, post-fall management procedure includes the following steps except: do not move the patient initially, reassure the patient, call for assistance, mobilize cervical spine if head and neck is reported as suspected, check for other potential injuries.
Except you should not.
Except you should not.
We're answering all alphabets D, B, C, three of them.
Yes, please read. Post-fall management procedure includes the following steps: do not move patient initially, reassure patient, call for assistance, mobilize cervical spine. If head and neck pain is reported or suspected, check for other potential injuries.
So C would be the answer. Right. Yeah.
C would be the answer.
The
Normalized
consensus
cervical
is
spine if the head and neck pain is reported or suspected.
okay. Again, primum non-necessary. If you don't know, then you don't do further harm.
What is the definition of the pressure ulcer? You all know the definition of the pressure ulcer. I think you all will be answering this well. Yes, localized injury to the skin or underlying tissue.
Very good.
Next one is presence clinically as aberration, blister, shallow crater. Which stage is this pressure ulcer? Yes, stage 1. Good. Next one, which of the following can cause phlebitis? Trauma, problems with clotting, changes in how blood flows through veins. All three answers are correct. Yes, all are correct. The most common type of medication error is wrong drug, wrong route of administration, administering improper dose, wrong patient. Very good. Administering improper dose. Most of the time, maximum they administer correctly, but at times improper dose. Every IV medication has the same rate of infusion, whether it is true or false. False. Which type of medication error is an incorrect administration technique or route? Prescription, transcription, dispensing, administration, monitoring error, documenting error. The documenting error. Correct. What does the CDC recommend to do after needle stick injury? I'm sure all of you know this. Wash area with soap and water. Report supervisor. Yes, both A and B. How can needle stick injury, sharps injuries can be prevented? Needle should not be recapped. Discard waste immediately. Do not leave sharps unattended. Do not overfill the puncture proof. All the above. Yes, all the above. I think they've answered everything well.
Yes, I think it should be the fruitful lecture. You could stop the share screen. Yeah. So thank you so much, Ms. Sireesha. Very insightful one. And I could see from the students' answers that it was pretty much fruitful as well. And at the end of our conclusion, I think I would like to actually thank all the audience and all the students and all the senior nurses as well for actually taking your time, a busy time in the day, and listening to the lecture and interacting with us. Once again, I thank the Apollo administration and our nursing in charge, Sireesha, and Mrs. Susha as well for helping us in taking the nursing education. And the Indian Society of Critical Care Medicine, as always, I think we are pro-educative and we want our nurses to be equal to us and maybe more better than us as they are all. And myself, Dr. Deepak, I again once thank you. And as I think I would like to sign off with a quote that God has selected their best angels and made them nurses. Thank you all the nurses again. Thank you.
Thank you so much.